With kind permission of Dr. Purvish, Parikh and Dr. Sudeep Gupta, good evening, ladies and gentlemen. A very, very warm welcome to She Shaping Her Evolution. We all have been waiting for 16th of September 2022, where we learn lessons of 2 decades of international academic research in breast cancer. It's my honor and privilege. I'm Dr. Manoj. Today, we are live on 34 locations with more than 600 oncologists across India. And I also feel very happy to wish good morning, good afternoon, and good evening to many international oncologists who are logging in great numbers. Some of them are from Europe, some of them are from US. A warm welcome to our international speaker. I would leave the introduction part to our chairpersons and the program directors. A warm welcome to our chairperson, Dr. Purvish Parikh, very, very known to the global arena in the field of oncology and hematology, professor and head of clinical hematology at MGM Jaipur, and previously professor and head of medical oncology at TMH, Mumbai. It's my honor and privilege to give you a brief introduction about INTAS and Accord. We are pioneering innovation for bettering outcomes. Just to give you a perspective that today we are present in almost 80 countries plus, providing quality care to cancer patients and other work. We are very happy to introduce in last decade more than 15 biosimilars. And today we are humbled to inform you that we are the #1 Indian oncology company in India. We have more than 15 factories and our own outlets. Majority of them are US FDA approved. This is some of the glimpses, and I invite you whenever you are in Ahmedabad or other parts of the world to visit our locations. We now have 4 biosimilars in UK and Europe: GCSF, PEG-GCSF, trastuzumab, and teriparatide. And we have also succeeded in doing many collaborations, including the Excellence Award by various bodies. We are going ahead with teriparatide, which is the 4th biosimilar in Europe. We are our INTAS Plasma Fractionation Center, which became a center of excellence, especially during COVID time, is also going global. We are trying to have our own fractionation unit in London. In addition to this, our licensing and in-licensing agreements with Europe, US, and Japanese companies continues. INTAS and Exantia signed an exclusive agreements for wet AMD case with ranibizumab, and we continue to pioneer, including with bevacizumab. We are also very happy to say that one of our sister concern, Lambda, is a pioneer in global clinical trial, and in Canada we have tied up with Novum. Our own patented drugs such as docetaxel and paclitaxel. Docetaxel in India, we have benefited close to 18,000 plus patients, and paclitaxel, which is nanosomal paclitaxel lipid suspension, we now have benefited 5,000 plus patients. Very recently concluded international event ESMO, we had our presence on docetaxel and paclitaxel, and a lot of international faculties took a walk to our booth to learn about these 2 patented technologies from India. We have also recently tied up in Europe to give you innovator, Relugolix, and we assure you that at least each year we will give you 1 biosimilar for the global world. Our step and endeavor continues, and we would continue to work with all the oncologists and hematologists of India and global world to ensure a quality care. 2 other areas I wanted to update you. One is CAR T-cell therapy, and second is all the immuno-oncology drugs which you badly need for the global cancer community. And we assure you that after respecting the after respecting the research endeavor, we would be in a position to give you all the immuno-oncologies. And we also hope to have some success on CAR T-cell therapy. With this, I close, and I invite our program director, Dr. Purvish Parikh sir, to take it forward from here. And a warm welcome to Dr. Sudeep Gupta.
Thank you very much, Manoj. As soon as Lalan can show the slides, I will start introducing the colleagues who are located. So as Manoj mentioned, we have more than 34 centers which are logged in. Professor Sudeep Gupta is director and professor of medical oncology. He is director at ACTRACT, and he is a world authority like Martine on breast cancer. Next. We in Mumbai, the chairpersons are Dr. Suresh Advani, who is my mentor, and Dr. Tapan Saikia, who is at Prince Ali Khan Hospital. Next, please. Coordinating from Chennai is Dr. T. Raja. Next. And from Delhi, we have Dr. Meenu Walia. Next. From Bangalore, it is Dr. Leenu Jacob. And one of the Bangalore colleagues, Dr. Govind Babu, is here in Madurai. Next. From Hyderabad, we have Dr. Vamshi Krishna. Next. And as mentioned earlier, there are several 34 other locations from where people, doctors are logged in. Next. Next. Now it is my honor to introduce Professor Martine Piccard. She is MD and PhD in oncology. She is honorary professor of University of Brussels and scientific director at Julius Bordeaux Institute in Belgium. She has held presidencies of almost all the important oncology societies and associations in Europe, including ESMO, ECHO, and EORTC. She has served on the board of ASCO as well as AACR, which nominated her as a fellow of the AACR Academy in 2013. She has been one of the co-founders of the Breast International Group since 1996. And we are proud to say that we are also members of BIG by 3 associations from India. For the research achievements of BIG in particular, for the approval of new anti-cancer drugs for breast cancer, she has received innumerable prestigious awards. And we always find new publications from her side, which is original data. And she's author and co-author of over 670 publications in international journals. This is just a very brief introduction of all the achievements that Professor Martine has. I don't want to take up more of your time. Over to you, Professor, for your lecture.
Thank you very much for this wonderful introduction. So, dear colleagues, it's a great pleasure for me to be invited to give a talk today, and it was particularly nice to give me freedom in the choice of the topic. So you will agree with me that we are witnessing an exponential growth in the development of very expensive oncology drugs. And it will become very difficult for countries to pay for all these drugs. So clearly in India, what you have started to do as a possible answer to this phenomenon is to produce high quality generic drugs. And on my side, what I've tried to do is to reinforce academic research. And the message I would like to give you today is that this is very important if you really want to offer to our patients the right treatment, the treatment they need, but it is becoming very, very difficult to preserve academic research in a world where lots of the clinical research performed is in fact dominated by the pharmaceutical industry. So let's go into the talk itself. Oh my goodness.
Ma'am, have you shared your slides?
Yeah.
Ma'am, can you reshare it? We can't see them.
Yeah.
Sorry to interrupt you.
I start again. Yeah.
Yes, ma'am. Now you can see your slides. Thank you so much.
Okay. Okay. So, well, it's well known by everybody in the audience that, of course, we have made significant progress in controlling breast cancer in the world, with the mortality from breast cancer decreasing in many regions. And the explanation for that is, of course, on one hand, screening mammography, but also a much better multimodality treatment approach to the disease. And what we've also witnessed in recent years is really a very nice de-escalation in breast cancer surgery, and now also a de-escalation in breast cancer radiotherapy. But what is more worrisome is that we witness exactly the opposite phenomenon in terms of drugs, and in particular adjuvant systemic therapy for breast cancer. And you know that a woman today, for example, a woman who presents with HER2 positive, hormone receptor positive breast cancer, might be treated by a complex, by different modalities, and can be on a very long treatment. She will be offered after surgery chemotherapy together with a targeted drug, trastuzumab, sometimes trastuzumab and pertuzumab, then she will get radiotherapy, and then she will continue with a very long endocrine therapy, particularly if she is node positive. So clearly what brought us there is the fact that as medical oncologists, we are very well aware that we can only cure early breast cancer. Still, we are unable to cure metastatic breast cancer, even if there also we have seen important progress, particularly in the last 10 years. And it's very obvious that there is a risk of over-treatment of women with early breast cancer, theoretically also, but it's less frequent, a risk of under-treatment, and also a risk of picking up the wrong treatment. But the fear that we might make the wrong decision is clearly contributing to this tendency of over-treatment of women with early breast cancer. And no doubt that we have seen an important therapeutic escalation. We treat more patients with drugs today. We expose them to drugs for longer times. Endocrine therapy can be as long as 10 years. And we tend also to give more drugs. Now, in this age of escalation of drug treatment, academic research remains very important. And what is academic research? It is the garden ensuring that the patient's needs remain top priority in randomized clinical trials. But that implies that medical oncologists taking care of women with breast cancer, patients with breast cancer, can play an important role in the design of the trials. And that is becoming very, very difficult. One of the reasons we decided in 1996 to create the Breast International Group was to somehow try to preserve academic research in a world that was increasingly dominated by pharma. Of course, the other reason was also to avoid duplication of efforts to try to work more often together, particularly for difficult questions. And as you heard, India is part of the Breast International Group, although I must confess that we have not spent enough time to discuss with our Indian colleagues what are the research questions that are most important to them for their country. We can come back later in the discussion to this important point. So let me explain to you a little bit the history of the contributions of BIC in 3 domains. The first one is improving cure rates for HER2 positive breast cancer with targeted therapies. The second one is designing more effective endocrine therapies and contributing to their tailoring. And the third one is identifying women who can be spared chemotherapy. So these are 3 domains where BIC has been heavily involved. And I will try to explain to you the positive experiences we had, but also the negative ones. So talk a little bit about what is behind the curtain. BIC is, of course, well known for its important contribution to HER2-positive breast cancer, particularly better adjuvant systemic treatment for early disease. We did participate to 2 strategies, single HER2 blockade with trastuzumab and more recently dual HER2 blockade. We did not, unfortunately, play an active role in the third strategy, which has been, of course, the transfer of TDM1 to the post-neoadjuvant setting. And we will come back to that later. So, as you know, what we have seen in the last 15 years is a fantastic development of targeted drugs for HER2-positive breast cancer. We have 2 anti-HER2 monoclonal antibodies, trastuzumab, the very first, the parent drug, which binds to domain 4 of the external portion of the HER2 receptor. And then the other anti-HER2 monoclonal antibody, pertuzumab, binds to domain 2 and will inhibit dimerization of the receptor. And then we have also seen the development of small molecule tyrosine kinase inhibitors, starting with lapatinib. But more recently, we have seen other drugs, probably better drugs, such as neratinib and tucatinib. BIG was involved in the HERA trial, in the ALTO trial, and the Affinity trial. Then I will very briefly review those with you. Okay, so as you can see, a big strength of BIG, of course, is the possibility to recruit large number of patients in these adjuvant trials in a very short period of time. So, for example, the HERA trial recruited over 5,000 women in 43 months. The ALTO trial, which was a very large 4-arm trial, recruited more than 8,000 women in 49 months, and the Affinity trial, 4,800 women in 22 months. So all over these years, we have recruited over 18,000 women. And you see the distribution of the regions which contributed to these trials. We have, of course, contributed to the demonstration that trastuzumab is really an important drug, a life-saving drug that produces a 6 to 7% absolute reduction in the risk of relapse and death. And of course, the price to pay for this improvement is a small increase in congestive heart failure that ranges between 0.8 and 1.3% in the trastuzumab adjuvant trial. So clearly the benefit exceeds the potential harm. And the good news, because we have been following women for up to 10 years, we have seen no signal of late cardiotoxicity. Now, what people don't know is that the HERA trial was very important to consolidate the Breast International Group many years ago. It was, in fact, the very first example of a model that I personally think is the best model of partnership between academia and industry for the conduct of these registration trials, which are going to change clinical practice forever. But this model that we have been defending now for many, many years is, what can I say, is more and more difficult to sell to companies. And this is a big worry to me. So the way BIG functions is the following. The clinical trial database is under the control of academia, not under the control of pharma. So we don't share the efficacy data with pharma during the conduct of the trial, but we do share the safety data. And this is, of course, very important. So we have very regular meetings, in fact, every 2 weeks with the pharmaceutical industry partner, where we discuss all the problems, logistical problems, but also potential side effects and the best way to solve these problems. The protocol is usually prepared in collaboration with pharma, as well as the statistical plan. But of course, there is a very important role played by the independent academic statistician. And then very importantly, we collect biospecimens a lot of them in these trials, and they are under control by academia. And we feel that this is very important, not because pharma cannot do a good job with these specimens, they also have very good scientists, but we think that having the biosamples controlled by academia ensures the fact that if you discover that it's only a small subgroup of the patient population that benefits from the new drug, this result will be published. And we are not totally sure that this is the case if all the trial data, the biospecimens are controlled by pharma, which of course has commercial interests. And then the role of academia is also to ensure long-term follow-up, because once the drug is registered by pharma, well, they will have their interest in other drugs, and they will not be so keen to continue to follow patients in a trial that was a success. Now, this hybrid model has strengths and weaknesses. I believe that a strength is that commercial bias and conflicts of interest between the parties are reduced. I also think that in this model, academia has a sense of ownership of the trial. We don't feel that we are just there to put our patients in a trial that we absolutely have no control upon. Pharma avoids investing huge amounts of money into a black box because in our model, we keep them informed very regularly on all the aspects of the trial. And for patients, we think that the model guarantees full transparency of results, high quality of data, and long-term follow-up. But there are also, of course, vulnerabilities of the model. Now, what we learned in working so closely with the pharmaceutical industry is that, of course, these trials, the large adjuvant trials of thousands of patients, are incredibly expensive. And so pharma will not suffer delays on agreed milestone. We need to be 100% efficient. And that implies a very strong leadership in academia. So you need a person who is going to drive the study. And then for pharma, the model requires trust in academia. And this is very difficult, I can tell you, also because there is such an important turnover among pharmaceutical industry people. So if you start building the model with 2-3 important people from a company, 4 years later, if you have a second study, the people you will have to talk to in this particular pharmaceutical industry will probably be new people. They have no idea of what happened before. Now, what I think we have not been able to do very successfully, and this is true for the pharma trials, but also, unfortunately, for these trials that are partially controlled by academia, we have not been able to conduct very successful translational research. In fact, if you think about our clinical practice with early HER2-positive breast cancer, we still rely on one biomarker, which is HER2 overexpression or amplification, in spite of the fact that there have been huge efforts at finding biomarkers beyond HER2. We have been looking at other membrane receptors, at their ligands, at downstream signaling pathways, at the microenvironment with the TILs, at tumor heterogeneity, and all this work has generated a lot of publications. So this is very good for the CV of people in academia. But if we want to be totally honest, we have not been able to validate these biomarkers up to the point that their clinical utility is completely demonstrated and they are recognized by guidelines as biomarkers that you need to measure in your clinical practice. And of course, it is my own bias to think that we are all very naive by thinking that in doing these translational research efforts, in all these successive trials, we are going to better understand the disease. I think cancer is just a terrible disease, a very clever disease, and the only way we are going to understand cancer better is probably by sharing thousands of data. So what we need now to do in the future, but there are many barriers, we need to share the biomarkers data of all the trials. And that's the only way we are possibly going to identify biomarkers that are really helping with treatment individualization. Okay, dual HER2 blockade was a slightly different story. So clearly, the story of the HERA trial that was done by Big and presented at ASCO in 2005 was a very successful story. As I told you, it was this first new model of working with pharma. We had been able to recruit faster than our US colleagues, and we were at ASCO together with them to present these fantastic results. So this trial really helped the Breast International Group to exist, and it really was a way to convince investigators who were still wondering whether this was a good idea or not, that by collaborating together, we could achieve fantastic things. Now, the story of dual HER2 blockade is interesting. It is a little bit less impressive in my view. And what happened, in fact, is, and you know that, is that all of us started to be incredibly excited by the results of a series of to be achieved either by combining trastuzumab with a small tyrosine kinase inhibitor, so that's the vertical blockade, or by utilizing two anti-HER2 monoclonal antibodies like trastuzumab and pertuzumab. And in fact, you can see all these famous neoadjuvant trials generated very interesting results in terms of PCR. Nevertheless, two trials did not show an improvement in PCR, NSABP-B41 and CLGB-40601. But we were excited and convinced that this strategy was going to be very effective in the adjuvant setting. As a matter of fact, today we have two of these strategies recognized, registered by EMA and by the FDA. It's trastuzumab plus pertuzumab and trastuzumab followed by neratinib. As a matter of fact, 3 trials explored the concept. ALTO, which was conducted by us, Extenet, which was the trial exploring the sequence of trastuzumab and neratinib, a difficult study because the company changed during the conduct of the trial, and it was really the investigators who had to fight to continue to follow patients. And then Affinity, which was also a big trial. And, you know, the ALTO trial, which explored dual HER2 blockade with lapatinib, is considered a negative study. But if you look at the hazard ratios, it is in the same range as for the other trials. So in fact, this strategy also works. What explains the failure was the statistical plan of ALTO, which was changed during the conduct of the study. And the alpha was split between the sequential arm, trastuzumab followed by lapatinib, or the combination arm. And the p-value for the combination of 0.048 was not considered statistically significant according to the plan. Anyway, at the end, the message that we get from these trials is that, yes, dual HER2 blockade works, but not to the extent we had been hoping for. So the magnitude of the benefit is smaller than anticipated. And another important message is that it's a strategy that needs to be reserved for the high-risk women with node-positive disease. In particular, in Affinity, we saw no effect whatsoever in node-negative disease, which is something that I am still wondering why it's the case, because in many adjuvant studies, the hazard ratio is the same for node-negative and node-positive. It's the absolute benefit, which is smaller in node-negative patients. But here the hazard ratio was 1.0, no effect of the addition of pertuzumab. And you see these curves with these modest improvement on the left for the node-positive patients and absolutely no difference for the node-negative patients. Now we have, of course, done already a lot of translational research efforts in this affinity trial, but I can tell you that we have not found any good explanation, in particular for this observation. Now, when we run these adjuvant trials, of course, we need huge number of patients, and we compare treatments that are given completely blindly. The tumor has been removed by the surgeon, we apply the drugs, and then we wait for the events. So it gives you a very strange feeling that you experiment a treatment in your patient with no ways to find out if you are really helping the patient. So this might change in the future with ctDNA monitoring, but right now, this is the reality. So what happened then after 2015 was, of course, rapid growing interest in neoadjuvant systemic treatment. And this is because, of course, we understood that complete pathological response is a surrogate for long-term outcome, not a perfect one, but it is nevertheless a surrogate. And we know that patients with residual disease are not going to do very well, and that these are the patients who deserve treatment escalation. And indeed, it was demonstrated in a very important trial, the Catherine study, that you can help these patients with residual disease after systemic neoadjuvant chemotherapy and anti-HER2 therapy by giving them TDM1. And I think that this trial indeed had a very important impact on treatment guidelines. You know that almost all guidelines now for tumors less than 2 centimeters strongly recommend to go for neoadjuvant systemic treatment rather than adjuvant systemic treatment. And another consequence of this is the excitement for de-escalation of adjuvant systemic treatment in HER2-positive breast cancer. And indeed, the neoadjuvant model will allow you to do that better than an adjuvant model because you will identify patients, those with residual disease, who cannot do well with de-escalation. Nevertheless, we need to be very cautious because we are talking here about curative treatments. So we have to be conscious that these de-escalation attempts can potentially be dangerous for our patients. So this is just a figure very familiar to you, showing the efficacy of TDM1 compared to trastuzumab in women with residual disease. And by the way, I hope we will soon hear what are the overall survival results of this trial. And here you see some interesting attempts at de-escalation. The first trial, the Dutch trial, was a small trial of about 423 patients, which nicely showed that you could get similar pathological complete response rates with 9 cycles of paclitaxel carboplatin compared to 3 cycles of FEC followed by 6 cycles of paclitaxel carboplatin. So the goal here clearly is to get rid of anthracyclines without compromising the outcome of patients. PCR rates were identical, 3 event-free survival rates were identical also, but you have to look at the confidence interval. So if you look at the 95% confidence interval around these figures, you see that there is still a lot of uncertainty. So a small trial like this one cannot definitely change practice. And there are 2 relatively large studies running now, which hopefully will allow us in the future to de-escalate treatment in some women, de-escalation being avoidance of anthracycline. So just a few more minutes, the trial that we done in BIG, Decrescendo, is slightly different from the US trial. It is selecting women with T2 and 0 disease because we are very scared to de-escalate treatment in women with large tumors and clinically positive nodes because they can relapse in spite of obtaining a PCR. And we have also focused this trial on hormone receptor negative disease because for a variety of reasons, we think that these tumors are more addicted to the HER2 pathway, and therefore there is more justification to use dual HER2 blockade in these patients. But you see, the two trials are very similar. There is an induction with a taxane and dual HER2 blockade. And then if patients have a PCR, we do not give more chemo. We continue with dual HER2 blockade. And in both trials, which are single-arm de-escalation trials, the aim is to reach an excellent 3-year relapse-free survival. And you see here the details of this big trial, the Crescendo, which is now actively recruiting. The goal is to recruit over 1,000 patients. And what is, of course, safe in the trial is that patients who do not have a PCR will access T-DM1, and the ones that have really bulky disease will also get anthracyclines after surgery. So that is the story of what BIG did in HER2-positive breast cancer. We participated to an escalating effort. And now we are trying to very cautiously de-escalate treatment. Now, the very courageous trial, we have not had the courage to do. And the very courageous trial, that would be an important trial for regions of the world like India, is to ask the question whether you can stop treatment in a patient with PCR and not continue by giving them trastuzumab or trastuzumab and pertuzumab. And in fact, there is a trial in the UK which is going to address this question. It's called the HER2 Radical study. Now, endocrine treatment has been also an area of great interest of the Breast International Group. And you know here that, of course, the strategies that we have exploited in practice until recently are tamoxifen, a very old and very effective drug, aromatase inhibitors for postmenopausal women, ovarian function suppression for premenopausal women. So I'm not going to talk about more modern approaches with CDK4/6 inhibitors. And what BIG has really wanted to contribute to is how can we select the right endocrine strategy for the right patient? And of course, we have been running two very important research efforts. On one hand, the BIG 198 trial recruited over 8,000 postmenopausal women. And then in premenopausal women, we did run the soft and text trials. And I can tell you that these trials were not at all interesting to pharma, were extremely difficult to run because of very modest financial support. So many people don't know that back in the 1980s, when we met with Novartis to discuss these trials that would incorporate letrozole and compare letrozole to tamoxifen, Novartis was only interested in the head-to-head comparison, two-arm, tamoxifen and letrozole. And it was a big fight with the company to obtain permission to also run a slightly more sophisticated trial with sequencing strategies. And if you read the publication of BIG 98, what you will find is that the sequence of letrozole for 2-3 years followed by tamoxifen was very, very similar in terms of efficacy to the 5 years of letrozole. So it was an important observation that matters to our patients, because you know that up to 40% of women do not tolerate endocrine treatment and aromatase inhibitors in particular. And what this trial allows us to tell these women is that they can change after 2 years for the old drug tamoxifen, and this will not compromise their chance of cure. In the young women, we did run this trial soft and text, which compared tamoxifen alone or a combination of tamoxifen with ovarian function suppression, or a combination of an aromatase inhibitor, exemestane, with ovarian function suppression. And essentially what the message from these trials is that tamoxifen is good enough for many women. Some women will have a benefit from the addition of ovarian function suppression to tamoxifen, but only if they are at high risk of relapse. The benefit is in the range of 3% in overall survival, which is not negligible. And finally, the combination of exemestane and ovarian function suppression is better than the combination of tamoxifen and ovarian function suppression. But here, the demonstration of this additional benefit is essentially for the very young women at high risk to whom you have already decided to give chemotherapy. So important research efforts in these premenopausal women that are helping us to do a better job in clinical practice. And there is a possibility, a website where you can enter the characteristics of your patient, and based on the text and soft trial, you will get the information of what is the benefit you can expect from a more aggressive endocrine treatment strategy. So the addition of ovarian function suppression, which, as you know, is going to generate more side effects. And then we did run, and we completed recruitment of this interesting trial called POSITIVE. The goal of this single-arm study is to demonstrate that interrupting adjuvant endocrine therapy for 2 years to allow a pregnancy is not harmful. Important question, because women get pregnant later and later. And so if they get breast cancer at age 32, and if they have to go for a very long adjuvant endocrine treatment, what is their chance to become a mother? So this trial recruited more than 500 women in 14 European countries. The recruitment is completed. The first presentation of the interim results of this trial will be presented in San Antonio this year. It was a very hard study to run, no interest from pharma, so we had to fight to get the financial support from a lot of foundations. And I'm very pleased to tell you that 365 babies were born because of this particular study. And the last point, the last domain I would like to briefly touch upon is this effort of 15 years to try to validate a signature that identifies women who can be spared chemotherapy, women with luminal breast cancer. So for women with luminal breast cancer and 0 to 3 positive nodes, you know that many of them will be cured with surgery, radiation, and endocrine treatment. Chemotherapy will benefit, of course, a proportion of them, but it's difficult to identify who are these women who need chemotherapy. And clearly, there has been a great deal of overtreatment with chemotherapy in the last 2 decades, probably more in the US than in Europe. So how do we decide whether a woman needs chemotherapy or not? You know that, of course, our pathologists have a big responsibility there. We are going to ask them a lot of information. The list is there on the left. But some of these evaluations are quite difficult. They are pathologist dependent. There is not a good reproducibility among pathologists, particularly for the Ki-67. And so in the early 2000s, we got extremely interested in this publication by our colleagues from the NKI in Amsterdam. They had discovered 70 gene expression signature that seemed to be able to make a distinction between women with luminal breast cancer that had an excellent prognosis without any systemic treatment, and another group that had a poor outcome without systemic treatment. So these were all women who had only surgery plus or minus radiation. And we decided at that time, not knowing how difficult it was going to be, of course, that this was a very interesting biomarker and that we would need to do everything possible to bring this biomarker to the highest possible level of evidence so that its clinical utility is demonstrated, and it gets reimbursed and used in clinical practice. Okay, now the hypothesis that we put forward was that this genomic assay would outperform the pathologist-defined criteria by reducing the prescription of adjuvant chemo without impairing outcome. And after 3 years spent at an external validation of the 70 gene signature in other hospitals than the hospital which had produced the initial publication, we decided to embark on this large MINDACT study that recruited over 6,600 women in different European countries. And all these women had a classification done by Adjuvant Online. So that was their clinical risk. And of course, they had this 70 gene signature performed centrally in Amsterdam. And so we could classify these women into 4 groups: clinical low risk and genomic low risk. These women didn't get chemo. They only were offered endocrine treatment. Then at the opposite, we had the women clinical high risk, genomic high risk, who of course were offered chemotherapy and endocrine therapy. But then we had about 1/3 of the women in the discordant group. So clinical low, genomic high, but mostly clinical high, genomic low, 1,550 women. And these discordant patients were randomized to either believe the clinical classification or believe the genomic signature. And just to show you that, because Adjuvant Online doesn't exist anymore, you can now, with this table, identify how the patients were classified in MINDACT according to their grade, their nodal status, and their tumor size. So for example, for a grade 1 node-negative tumor to be considered clinical high risk, you see that you need a very large tumor of more than 3 centimeters. On the opposite, if you have a grade 3 tumor node-negative, as soon as it is bigger than 1 centimeter, it will be considered clinical high risk. And essentially, what we had to demonstrate in MINDACT was an excellent outcome for this group of women, clinical high risk, genomic low risk, not receiving chemotherapy. And we were successful at the very first analysis with a median of 5 years of follow-up. We could demonstrate that these women had 5-year distant metastasis-free survival close to 95%. And the lower limit of the 95% confidence interval had to be greater than 92%, and it was the case. So we were very happy, but we knew that a longer follow-up was needed because in luminal breast cancers, late relapses are not so uncommon. So we waited a little bit longer, and I will describe in a few minutes the results. But in the meantime, as you know, our colleagues in the United States did 2 very interesting trials, the results of which are in fact very much reinforcing the results of MINDACT. So I view these 3 large genomic trials as supporting one another. And importantly, they show exactly the same. The message coming out of these trials is the same. I have no time to go into all the details. You know that TAILORx was a trial for node-negative disease, that the women had an oncotype score, and that if this score was between 11 and 25, they were randomized to receive endocrine treatment alone or endocrine treatment plus chemo. And it was a non-inferiority hypothesis that justified this very large sample size. ERICSPONDER is a younger study, started later, focusing exclusively on women with 1 to 3 positive nodes, with a recurrent score below 25, and again randomizing these women to endocrine treatment alone or endocrine treatment plus chemo. MINDACT has a more complex design, but it takes into account clinical risk. which is something that we always do in clinical practice. In the States, in Taylorix in particular, clinical risk was not integrated in the plan. In every responder, you could argue that because the women had positive notes, they were almost all considered clinical high risk. And what has been interesting, I think, and we published that, I think I will skip this in the interest of time because it will take too long, but this is the important figure. So if you focus in the 3 trials on postmenopausal women, clinical high risk, what you can see is that if they have a low risk genomic signature, so a low recurrent score or low risk mama print signature, you are not able to see any benefit from chemotherapy. So these are the blue circles. You see the hazard ratio when you compare chemo plus endocrine or endocrine therapy alone. And the hazard ratio is more or less around 1. While in the premenopausal women, clinical high risk with a favorable gene expression signature, giving chemotherapy is associated with a better outcome. And these are the red circles. You see there that the hazard ratio, the point estimate in the 3 studies is in the same range, around 0.54, 55. So the 3 trials are able to indicate that withholding chemotherapy in postmenopausal women, high clinical risk, low genomic risk, is indeed something safe. But this is not the case for the young women. And the unanswered question there, of course, is it because we forgot to give ovarian function suppression to these women? And so that's going to be the next important question to address. And then finally, to tell you that, of course, we have been focused for many, many years on early breast cancer trials in the Breast International Group, and we have done very little for metastatic disease. One of the reasons being that the best studies there clearly are the ones conducted by pharma. And pharma has been responsible for the development of very nice and important drugs in metastatic breast cancer. The CDK4/6 inhibitors, they have made a big impact on the survival of luminal metastatic breast cancer. And all the drugs that were developed in the HER2 positive space were developed because of very good and large and well-powered pharmaceutical industry trials. So what could we do as an academic consortium there? Well, what we thought is that it was time to try to understand the disease. What we do today is not very optimal. We run the trials according to the different breast cancer subtypes, and we understand very little about the biology of the disease, the genomic drivers. So what we decided to launch is a very ambitious molecular screening program called Aurora, where the aim was to enroll 1,000 patients with metastatic breast cancer, and this has been achieved. We have enrolled close to 1,200 patients today, and we take these patients at the beginning of the history of metastatic disease. So they have not yet been treated for metastatic breast cancer, or they have received a maximum of 1 line. We must get then samples of the primary tumor and a metastatic biopsy. We will snap freeze a portion of the metastatic biopsy, and we will perform targeted exome sequencing on the primary and the metastatic lesion in parallel with germline sequencing. These results will be done real time and shared with the treating oncologist. On the other hand, we will put the samples on the side to later on perform RNA sequencing, copy number, aberration analysis, and we are also taking plasma every 6 months in all these women who are being followed for their entire history with recording of all the treatments they get. So every 6 months we save plasma for an analysis of circulating tumor DNA later on. We also have digital slides of all these women. The first results were published a year ago in Cancer Discovery, and the focus of this publication was on pairs. So pairs between primary tumor and the corresponding metastasis in terms of DNA sequencing, RNA sequencing, and copy number variation. And what we learned was that in that disease, breast cancer, new point mutations are acquired in only 10% of patients. So a lot of the mutations are already there in the primary cancer. However, in terms of copy number aberrations, there is an acquisition of new copy number aberrations in metastasis by approximately 30% of patients. We also found two mutations to be associated with a very poor prognosis, particularly in luminal breast cancer. And these are mutations in TP53 and mutations in this gene called LRP1B, which is a putative tumor suppressor gene. What we also found was that tumor mutational burden carries a poor prognosis. As you can see here, when you find a high tumor mutational burden in the primary tumor, it will have a poor prognosis, and the same is true if you find it on a metastatic sample. And this was particularly clear, again, in the luminal breast cancers. From RNA sequencing, what we could document is a phenomenon that is known, but that has been based mainly on immunohistochemistry in the past. At the time of metastatic disease, what we could demonstrate here is that a lot of the luminal A cancers change and become luminal B, or sometimes HER2 enriched. Overall, 11% of tumors switch to the HER2 enriched subtype, which could have consequences in terms of patient management. We also found that, and this is perhaps not so surprising, that the immune score, so the microenvironment, is immunosuppressive in metastasis more than in the primary tumor, and this is particularly true for liver metastasis. In lymph nodes, we don't see this, but in liver, we do see a very low immunoscore, and that probably needs to be taken into account in our trials. The good news was that if we classified the molecular aberrations found in Aurora according to the ESMO scale of clinical actionability of molecular targets, we found actionable aberrations in 1 out of 2 patients. The problem, of course, was that many of the drugs corresponding to these aberrations were not reimbursed at the beginning of the Aurora study in many countries, which explains that we have a low percentage of patients where the therapy could be matched to a genomic alteration, but this is now changing and is becoming easier than in the beginning of the program. So I think that we are there sitting on a very interesting gold mine for future research. We called the program Aurora because we were hoping that it would bring some light in the darkness, because this disease is just a terrible disease with no possibility of cure. Very difficult for women to live with this disease. Now, I can tell you, if I had to rename this program, I would call it Vertigo, because the amount of data that we are accumulating is absolutely huge and phenomenal. And clearly, we will need to get more funding to work with teams of artificial intelligence experts to be able to dissect this huge amount of data and hopefully to better understand the disease evolution and why some tumors, some patients respond very nicely to treatment and others don't. So I hope I wasn't too long. I thought that out of these experiences of clinical research at an international level, I could provide a few messages that hopefully you will find interesting. Thank you.
Thank you very much, Dr. Martine. That was a phenomenal summary of your lifetime's achievement in breast cancer. And now we'll move across the 6 main centers, having a 5-minute question and answer session for each of them. Shall we start with Mumbai? Over to you, Dr. Sudeep Gupta, to initiate the discussion.
Thank you, Dr. Parikh. Dr. Pickard, that was a wonderful talk, and especially your emphasis on investigator-led research, which provides unique insights. Are there any questions from anyone? I don't see anything in my chat box. So yes, someone has asked. So there is a question, and I will read it out. What is your experience and opinion on neratinib? Considering the risk of diarrhea, is it worth treating with this drug? And how does neratinib compare with other TKIs?
It's an interesting question. Of course, I will give you my personal view. First of all, I think a big mistake that has been done by us and by companies at the beginning when we developed these TKIs is to drop trastuzumab. It's a mistake. And I think that the reason why tucatinib is now considered like probably the most interesting TKI based on the trial that they did with the combination of tucatinib, capecitabine, and trastuzumab, showing great activity also against brain mets. This is the only company that has not dropped trastuzumab. So I think that dropping trastuzumab was a mistake and was a thing that, of course, they didn't do with tucatinib, and that explains probably why this drug appears more powerful. Now, neratinib unquestionably is a difficult drug to handle, but investigators have made serious efforts at handling this diarrhea, so you can now better tackle this toxicity problem. But I don't see where I will put this drug in my treatment algorithm, because if I think a patient is at very high risk and needs dual HER2 blockade, I go, of course, for the affinity regimen and not for the extenet regimen. And the reason is that you never know at what point in time the patient will relapse. So the sequencing strategy in a high-risk patient there is a risk. What are you doing if at month 11 under trastuzumab there are metastases? So I rather go for immediate dual blockade. So I am not using, in fact, neratinib in early HER2-positive breast cancer. And now, if I want to be honest, in advanced disease, we have a clear preference for positioning tucatinib there with the very good data that were generated by the trial.
So thank you for your response, Dr. Pickard. What you're saying is that despite the extended trial, the place of neratinib is a little bit unclear, both in early and advanced stage because of other strategies that may be more useful. There is another question. What is your view on the current flavor of the season, which is HER2-low breast cancer? And the results that we have received with one of the drugs, and what is your thought on this?
Well, first of all, I think these are very good news, that we now have these antibody drug conjugates that are that we can offer to women with metastatic luminal breast cancer. It's a new treatment modality. It is clearly shown to be better than standard chemo, and standard chemo we know is very unsatisfactory. We know that we sequence these traditional cytotoxic agents with very little success. So I think it is an important step forward. I don't think that we will need a new classification of breast cancer, because there is not a more aggressive biology behind these low HER2 cancers. But what we will need, of course, is the recognition of the patients who fall in this category. And there I have my worries. I have my worries because I don't think that immunohistochemistry has been optimized to really identify these patients in a robust fashion. We already heard also at ESMO that concordance between pathologists for recognizing a HER2-low cancer is very low. And then you can imagine the pressure on the pathologist. So I have a patient who is now endocrine resistant, has metastatic disease. I would really like to give these antibody drug conjugates. I need to demonstrate that the patient is HER2-low. And then I will push my pathologist. You know, you need to find some staining there. So I am really worried. And so I think we will have to work on better ways to evaluate this HER2-low category. I don't know if it's going to be through mRNA measurement or if it's going to be more sophisticated methods using immunofluorescence. But I'm hopeful that pretty soon we will find a way to do this in a robust fashion. Now, of course, there is another possibility. If trastuzumab deruxtecan is active in HER2-0, I'm not excluding this possibility because there is no HER2-0 cell. You know, there are always HER2 receptors, probably 2,000 in a normal, in a HER2-low 0 cell. So if the drug would show activity there, very striking, of course, and better than standard chemo, then you have no problem anymore. Then you do the HER2 test, you identify the HER2 positive, you know, the amplified tumors with 3+ overexpression, and then you can just, to all the others, give the drug. So this is something we don't know today. We will see in the coming months or so.
Thank you very much. And just to stretch that point a little further, since trastuzumab deruxtecan also works in HER2 positive and amplified tumors, then perhaps in some settings HER2 will go out of the window altogether because it works from HER2-0 to HER2-3+.
Yes.
Okay, so there is one more question. We know about the data from Monarch E, which is the adjuvant use of abemaciclib. And of course, you know, they did not integrate genomic classification into the biomarker profile. So what is your take on the role of abemaciclib in presumably in a patient who fits into the criteria of the monarchy but has a low genomic risk?
I need to be honest with you, right? Tell you what I think. And I must confess that I've been wrong many times in my expectations, but I'm still uncomfortable with the results. So at this point in time, I would not, what can I say? I would not fight with my government if it would say that it's not going to reimburse the drug as yet. I think the follow-up is still a little short. And what will probably be very decisive is the results of this last very large trial, Natalie, with ribociclib. So this trial, I hope, will disclose first results next year. And so two things can happen, of course. If it's positive, I think it will make me very confident that the CDK4/6 inhibitors have really a role to play in the adjuvant setting. If it's negative, like PALAS, then I will wait for the more mature results of Monarch E, and I will conclude that there is a real difference between these classes of drugs. You know, in metastatic disease, we had difficulties to see real differences, but then we will have to conclude that abemaciclib, which is indeed different from the two others, is a better drug. Who knows? But it's too early. And you know, I just don't like the way the trials were designed, including the big trial. You know, I must confess. So the way I would have loved to see these trials being done is with a window of exposure to endocrine treatment alone prior to surgery. Like in the POETIC study done by the UK, a very elegant trial. So you give your aromatase inhibitor for 2 weeks, And then you see if the Ki-67 decreases. Of course, it has to be done centrally. It's complicated, but let's forget for a moment that it is a difficult biomarker in terms of reproducibility. But what they very nicely showed is that if you have this decrease, you have an excellent prognosis. So you don't need then an escalation with a CDK4/6. This is the way we should have done the trials, taking into account the genomic risk and the endocrine responsiveness. And then you can really select out a group where it will make sense to spend a lot of money again, because that's going to be costing a lot of money, right? Then you feel more comfortable that you need to prescribe the drug. Anyway, so I don't find the story a nice one. Pallas was also a trial constructed in an old-fashioned way where, in fact, these trials take patients with a high tumor burden because that's a way to get events. But it's not because you have a high tumor burden that you respond to a drug, right? So this is something different. I wish we would have had the time to design these trials better, because now we are going to be stuck. A very high-risk patient, if the results of Monarch E are confirmed with an extra 2 years, and I think we might have these results at San Antonio. I think there will be an update. And if the update shows that the curves continue to diverge, we will, of course, have to pay for a drug like that in many women, because luminal breast cancer is very frequent.
Thank you, Dr. Pickard. That was a very nuanced answer to a difficult question. And of course, we will find what we will find in the very near future. And of course, you also mentioned earlier that your de-escalation strategies in HER2-positive breast cancer do take into account the baseline tumor burden. And all of us are somewhat scared in de-escalating treatment in patients with the highest tumor burden before the start of systemic therapy. So thank you very much. There are no more questions, I believe, from Mumbai at least. And I hand the screen back to Dr. Parikh.
Thank you very much, Dr. Sudeep. We now move on to Chennai, and may I request Dr. T. Raja to initiate the discussion.
Good evening, Dr. Parikh, and good evening, Dr. Sudeep Gupta. Very kind of you both to involve all of us. And I thank Professor Piccart for this excellent lecture. It's kind of a, real, it's kind of a live film on what are the efforts that she has. It's not about an individual trial, but what she has thought through all these, efforts, and how her her mind has really been either excited or disturbed as all these events unfolded. So it was very fascinating to hear your insights as you moved along, madam. It was fascinating. So therefore, it was heartening to hear your new efforts on the Aurora trial. So I am basing my question on that, our questions on that. Breast being one of the biggest, tumors, when you compare with the lung or even gastrointestinal malignancies, why is it that either by the clinical trial design or whatever is the reason, the impact of complete genomic profiling, comprehensive genomic profiling has not been what it should be in breast as compared to even, take any malignancy, be it lung or melanoma or GI, particularly with the fact that there are already established fact that there is this ESR1 and the retinoblastoma gene. Already they convey a message about your endocrine therapies. Again, big number endocrine therapies, but already you have, and then you have the ERVB2 mRNA level, and you have the PDL1 level, and you have you have even the genomic amplification of PDL1 genes on PDL2 genes, and ctDNA in colon cancers and TMBs in other malignancies. These are all already available biomarkers, and independently each one we know has impact on the various treatment that we do in breast cancer. And it is all, we see it for effect that ESR1 has profound effects on the endocrine resistance and so on. Why has not been a comprehensive effort on all these trials for having these comprehensive genomic profiling and then having it as some sort of a pre-planned? Why was not done, and why is that the effect was not there? Is it because breast inherently was already a high achiever and therefore we couldn't, or was that a lack of effort and coordination, as you said, madam? That's our first question.
Well, it's a fascinating and very good question. And I fully agree with you that, the breast cancer oncology community has been ahead for many, many years. And now it looks like it's no longer the case. Why is that? I don't know. It looks like in breast cancer, everybody is reluctant to go for a small population with a well-identifiable target. So even companies, but also investigators, are not fighting for conducting these more difficult studies in small segments of the population that are well characterized, for example, through sequencing. I think it will be the job of the new generation of investigators to start thinking a little bit more like the colleagues in other fields, like, for example, lung cancer. But you are fully right in your analysis. We are continuing to do these trials in unselected populations, hoping that because we are collecting blood or tissue, that a posteriori, we will be able to identify who really benefits from the targeted drug. And this never works. It does not work. When you do a very large study, arm A, arm B, arm A is better than B. And then if you want a posteriori to identify who really needs the new treatment, it's not at all working. And a big worry I have, for example, here is in triple-negative breast cancer. So triple-negative breast cancer is a disease with a high unmet clinical need, but it's a very heterogeneous disease. And again, when you look at the design of the trials that we are currently running with checkpoint inhibitors in the adjuvant setting, they worry me a lot because they are very old-fashioned studies where you randomize between chemo plus your immune checkpoint inhibitor. What does it mean? It means that if at the end of the day, the experimental arm is better than the control arm, we will be obliged to treat all the women. And we know that at least 50% of these women are cured with chemotherapy alone. We know that we can induce pathological complete remissions of high quality in TNBC. So I fully agree with you. I think it's now the job of a new generation of doctors to fight for these better studies. And if the colleagues in other diseases can do it, we should be able to do it also.
That question a little bit. I'm sure you're recently aware of the data that was presented by Professor Badwe and the Tata Memorial Group. Dr. Sudeep Gupta is also one of the authors on a very novel intervention of using, lidocaine just before surgery, and that led to a 29% reduction in the risk of, very stunning results they have shown. But what is more interesting is the hypothesis that they have said that the genomic profiling is the key, that the behavior has changed for the tumor. It's kind of an epigenetic silencing of the. Again, there is a big message there that even we are revisiting the question that patients have always been asking: biopsy, does it lead to any biopsy, any intervention? Does it lead to of the spread. So we always tell them, don't worry, everything is okay. This is the standard of care and all. But they have revisited the question, but then they have come out with a hypothesis that such an intervention leads to something about their genomic awakening or so, whatever you can call. Again, there is a bigger message about why genomic profiling in some way, a dynamic genomic profiling seems to be the key, and why it was not incorporated. But I think you have partly answered the question.
Yeah, but I didn't understand why this presentation was not in the presidential session. You know, I thought, you know, okay, I agree with the discussant, but the study will have probably to be consolidated, independently verified. But if this treatment effect is there, it is phenomenal. Of course, it is much larger than what we see with many of our expensive oncology drugs. And trials like that, they are going to become more and more difficult to run. But these are the trials that I admire most. And I would love to see more trials of this kind in the Breast International Group coming from regions like India. But if we could help, we should help you in doing trials like that. For example, the de-escalation trial of trastuzumab after PCR is typically a trial that also, if positive, is going to be important for your region, for everybody, but also for your region. So we need to help one another, because these are the important trials that we have to launch. The companies will continue to do trials to sell the drugs, but we are there to find clever ways of helping patients that are not costing millions of dollars.
Thank you, Madam. Dr. Sudeep Gupta is one of the authors, so we really are proud of him, and we want to congratulate him and his team that they could dare to put up this effort and then come out with a novel outcome and a novel hypothesis on that. So relating to your answer, a couple of my colleagues have asked two questions. I'll just combine. Both of that boil down to a very basic, what you touched upon finally. In a country like India, cost is always an issue. So, you know, how do we choose when we have a cost as a reality challenge in front of our patient? How do we choose? And therefore, whether the role of the markers like PDL1, BRCA1, 2, little out of the, sometimes we can't stick to everything that is there in the guidelines. So these 2-3 questions are related to that. Cost and reality biting as it's not exactly academic, but it's real clinic. And how do we face the question? You are a very hardcore academician, but from a clinician's point of view, can you, you are one of the doyens of this breast oncology, but can you tell us, what do you think about this whole conundrum? Thank you, Madam.
So here I have another story to tell you. When back in 2012, I was fortunate to lead the ESMO for 2 years. And you know, 2 years is not a very long time, and you have to think, what can you really do to make an impact? And I had been very impressed by cancer mortality figures in Europe, showing higher mortality rates in Eastern Europe compared to Western Europe. So I decided to travel to Eastern European countries and to talk to the oncologists there. And they came and they said, we are so frustrated. We are unable to convince our governments to reimburse really important life-saving oncology drugs. And at that time, an example was trastuzumab. I came back from this trip and I started to think, this is a problem for the entire world, you know, that we will have difficulties in offering expensive treatments to all our patients. So what can we do about that? And when do we need to fight for a particular drug or a particular biomarker? And this was how we started the thinking around the ESMO magnitude of clinical benefit scale. At the beginning, when I proposed to do something like that, in ESMO, there were people very scared. They said, oh, you know, this is going to upset the companies. Well, it didn't happen. The companies were telling us it's much better than this kind of scale is developed by physicians rather than by administrative people in an office who have never seen a patient. So I'm not saying that the scale is perfect, but what the scale allows you to do is a ranking of new treatments. In the palliative setting, for example, you can rank the drugs from 1, which is very low, all the way up to 5, which is really good. So the valuable drugs have a score of 4, 5 on the scale. And I think that this is perhaps something that can help young oncologists. So they have a patient in front of them. They would like to give a new drug. Do they have to really convince the patient that the patient has to sell their house, spend a lot of money? Well, they can look at the scale. You know, if the drug has a score of 1, 2, or even 3, it's probably not worthwhile. So I think this is one way of trying to manage this difficult situation in clinical practice.
Right. Thank you, Dr. Raja. We now move on to Dr. Meenu Walia from Delhi. Meenu, over to you.
Thank you, Dr. Parikh, and thank you, Dr. Sudeep, for setting the set. And before I begin, I must compliment Dr. Martine for a very insightful and meaningful discussion today. So in a country like ours, where I think financial toxicity is also that we should be talking now much more openly, and the value of these investigator-led studies, that actually should be the way forward. And we at India at present are really very excited about the study from Dr. Sudeep Gupta and Dr. Badwe and team from Tata about this such a low cost molecule, and maybe what Dr. T. Raja just spoke about being given as a something like lignocaine being given in the preoperative setting and decreasing recurrences to such a huge amount. Maybe it looks like if these are the kind of things and whatever hypothesis, however it can be explained, but these may be the way forward. And there are a couple of questions from our center also, where people seem to be talking about a lot many contexts and including the financial aspects also. Something like Dr. Piyush wants to know that we know that a double HER2 blockade in the neoadjuvant setting is much better than a single blockade. So is there a role of since we have our own generic lapatinib also, so what are your comments on neoadjuvant lapatinib plus trastuzumab along with chemo in the neoadjuvant setting? Do we have any studies, or does it seem to be an effective strategy?
Well, the answer to this interesting question is yes. The Breast International Group conducted a study called NeoAlto, and NeoAlto was a comparison between trastuzumab and paclitaxel, or lapatinib paclitaxel, or lapatinib plus trastuzumab and paclitaxel as neoadjuvant treatment, with a comparison of pathological complete responses at surgery. And then the same treatment was continued after surgery, but all patients got anthracyclines. And if you look at the pathological complete response rates, they were clearly improved with the dual HER2 blockade using trastuzumab and lapatinib. So I think this combination is a good combination. It's more difficult to handle in patients because of the incidence of diarrhea. In the big ALTO study, we had a lot of problems dealing with this toxicity. We had a lot of dose reduction. So this may have also contributed to the results, but I showed you that it's not a negative trial. ALTO shows a reduction in the risk of relapse with a hazard ratio of 0.84, and the p-value was 0.04. So it's the statistical plan that had decided that to declare the combination as effective, the p-value had to be 0.02. So I think there is no harm in if you get this drug very cheap, like, you know, lapatinib at a very low cost, you have a high-risk patient, I think you could indeed consider giving this type of dual HER2 blockade instead of pertuzumab, which perhaps you don't have and which is going to be more expensive.
Yeah, excellent. I think, and just further to this also, apart from like in the adjuvant setting, we have enough data of like all these from trastuzumab in the adjuvant setting, and at present most of us still continue to go in spite of the evidence of lower time. We still continue to give for at least for a period of 1 year. But not infrequently you do see cardiotoxicity or financial toxicity, and you have to stop trastuzumab. So I'll rather say in a case of a cardiotoxicity where the LVF ejection fraction drops, in that setting, does it make sense to give lapatinib in the adjuvant setting? Any data on that?
It's a good question, and I think there is evidence in the literature that lapatinib is less cardiotoxic compared to the antibodies. Now, I am not sure that I would dare to give lapatinib if the ejection fraction is still quite low. But if you see after treatment interruption that there is some recovery, I also think that this makes sense then to re-challenge with lapatinib. It's an active drug. Again, if it's cheap in India, I think it's very reasonable to do this.
I think an important take home. Another thing, what we talked earlier, what we were talking about the low HER2 entity in today's date. So Dr. Randeep wants to know that considering the low HER2 entity that we know now, and in hindsight, would you like to reconsider this subset in the HERA trial?
I'm not sure I understand the question. If I would, so in the HERA trial, we didn't have these patients because HER2 low means FISH negative, right?
Yes.
So we could only enter patients in HERA if they were 2+ FISH plus.
Yeah.
So no.
So that is exactly the question. So considering that now we know that there is a entity known as low HER2 also. So whether, I mean, such a subset maybe there, do we see in near future such a subset be considered for these kind of targeted therapies too?
So I'm not sure, again, I understand the question, but clearly trastuzumab does not work in HER2 low tumors. That there has been a lot of evidence showing that. So it's this antibody drug conjugate which works, and of course it's a different molecule. Huh? It's there is a cytotoxic drug linked to the to trastuzumab. Trastuzumab then brings this cytotoxic drug to the cancer cells. So I don't think that trastuzumab will be revisited as a drug that can help these patients. And remember, NSABP did a very large study of adjuvant trastuzumab in HER2 low tumors FISH negative. And it was a completely negative trial. So for these HER2 low tumors, I think the future is for antibody drug conjugates, but not for anti-HER2 antibodies alone.
Yeah. So another thing, your take on, like Dr. Chirag from Ahmedabad, he had a question. What will be your take on about the premenopausal woman, talking about multi-gene signature? So does it have more relevance? What we are doing in present practice, more focusing on the postmenopausal lady? Should we be discouraging in the premenopausal woman because young women with breast cancer, or your emphasis for this should be equal in both, irrespective of the menopausal status?
Well, coming back again to the responsibility we have as oncologists in de-escalating curative treatments. From all what we have now learned from these trials, TAILORx, MINDACT, RxPonder, I think that these gene signatures find their clinical utility in postmenopausal. In premenopausal women, it's not really helpful for the time being, because in the 3 trials, you could see still a benefit, and not a negligible benefit, a benefit of over 5% in absolute terms, in IDFS or even in distant metastasis-free survival. So if you talk to a young patient with young kids, I don't think that she will take a risk to lose a 5% chance of cure. So right now, the signatures find their clinical utility in the postmenopausal women. High clinical risk, I don't think we can afford, like in the US, to do a recurrent score on everybody. You know, if you have a good pathologist and the pathologist tells you this is a 1 centimeter tumor, grade 1, Ki67, 5%, what's the point to order a signature? They do that in the US. We cannot do that. So you select high clinical risk, and then you order the test. And if the test comes back low genomic risk, it's great news for the woman, because getting chemotherapy is never nice, especially when you are over 65, you know. It can become very dangerous. So in postmenopausal women, the signatures are very helpful. In premenopausal women, we have not done a good job, because you have different regimens that were used in these trials. Some of these young women got 4 cycles of TC, others got a very strong anthracycline taxane regimen, and we don't know in which of these patients there was an ovarian function suppression effect. So the real question should be, if you have a low-risk gene signature in a young woman, can you avoid chemotherapy by giving ovarian function suppression? You see? So, and this is the question that is currently addressed in the OPTIMA trial. So there is still an important trial running in the UK. It's based on another gene expression signature, the PAM50, but anyway, it's also a good signature. And there, I think what they have done for the young women is a very smart thing. They control for ovarian function suppression by giving it to the women who do not get chemo. So it's a clearly important study, because it will tell you, if you give an optimal endocrine treatment with ovarian function suppression, can you forget chemo in the presence of a low-risk genomic signature? And we are probably going to join this UK effort, because we are very afraid that the trial as it is not big enough to give a definitive answer for the young patients. And it is a very important question for them. Can they avoid chemotherapy by just undergoing an optimal endocrine treatment?
Yeah. So just 2 more questions from our side, from the center. Do you see any role of extrapolating from the double blockade, any role of a triple blockade, like something like you have a pertuzumab and a trastuzumab and a TKI also in the new adjuvant setting, and any studies that are being ongoing, and maybe we increase the PCR rates to such an extent that in the adjuvant one can taper down to only oral TKI? Anything like this?
Well, I can tell you that it works very nicely in mice. So I've seen experiments carried out by in the lab of Kent Osborne in the US, where they have done that. So in mice, the triple blockade works very well. Well, I am a little bit afraid that in patients, what is going to be limiting is toxicity. I'm not aware of good studies with a large enough number of patients showing that this is really promising. But what you should know is that there has been a very elegant Spanish study that looked at dual blockade with trastuzumab and pertuzumab without chemo, using imaging, dynamic imaging to select patients who might not need chemo. So the trial is called FERGAIN. It's very elegant. It gives trastuzumab and pertuzumab on day 0. You first do a PET scan, and then you give 2 cycles. After 6 weeks, you repeat the PET scan. And if you have a decrease in SUV max by at least 40%, you consider that this is a response. There, the patients could continue without chemo. And they had a 37% PCR rate without chemo. So it's very, very clear that in this disease, there is a group of tumors that are HER2-driven, that are very sensitive to HER2 blockade, and for whom you might not need chemo. The problem is that investigators have good ideas. Then they run an elegant neoadjuvant trial, but they stop there, you see, and that is something that I am very frustrated, because if we do not construct on the discoveries we make, these good ideas, they never translate into better treatments in real world. And I'm not sure that based on this very interesting trial, they are going to, or somebody is going to demonstrate that these are really solid data. But there was no lapatinib. It was just the 2 anti-HER2 antibodies without chemo in this particular FERGAIN study.
The last one from our center, this is Dr. Abhishek from Ahmedabad again. So he basically wants to know, like, does all triple negative, wherever you are giving neoadjuvant, which you select for neoadjuvant therapies, so do you give pembro, combination of pembro plus chemo to all, or there is a particular criteria where you select is adding immuno is almost much more imperative in that subgroup?
Yeah, that's a very pertinent question. You see, based on the Keynote 522 study, it is now very difficult in a disease like this one to decide as a doctor, or, you know, I'm going to drop this component of the regimen because I think the patient doesn't need it. I am pretty sure that it's too aggressive for many patients. And in fact, I don't know what is your experience, but in the real world, outside the clinical trial, to give carboplatin, paclitaxel, anthracycline, cyclophosphamide, pembro is really tough. But the thing is that if this disease comes back, it's just awful. So the triple negative breast cancer, even with immunotherapy, you know, the median survival is not more than 2 years. So immunotherapy there works, but it's not at all a miraculous treatment. So right now, I'm afraid we need to stick to this. And it's only in carefully designed studies that academia now has to take responsibility and cautiously see if we can drop a part of this regimen. For example, in patients who would have a lot of TILs in the tumor, where we know that they have a good prognosis, we could start in these patients by perhaps not giving the anthracycline component of the neoadjuvant treatment. And then we see at surgery, if we don't have a good results, we can always give the anthracycline after. But we will need to design these trials because it doesn't make sense to throw all these drugs at all the patients, given the heterogeneous nature of the disease. But it's going to take a long time. So for several years now, women will have to cope with this regimen. If you
Thank
can
you very
afford.
much.
So
Minu,
very
thank you very
important.
much.
Thank you so much.
Can we
Over
move
to
to the
Dr. Parikh,
next
sir.
center, please? Thank you, thank you. Lino, are you ready from Bangalore? Your turn.
Yeah, thank you, Professor Purvish Parikh, for letting us be part of the program. So I would like to thank Professor Piccard for that very insightful talk, especially opening our eyes on the need for doing more and more academic research with respect to de-escalation of treatment, especially for the right sort of patients. And probably telling us that we lag behind our radiation counterparts and probably surgical counterparts in the need for de-escalation. So we know that from the EBCTCG meta-analysis that most of the treatment components which we give, be it endocrine therapy or chemotherapy or the HER2 targeted therapy, the absolute benefit is somewhere between 5 to 8%. So my question would be, what do you consider as a relevant or a significant benefit? Is it 1%, 2%, 3%? So what would you consider as significant, especially with respect to the absolute benefit? Or is it something which we are, as doctors, are not supposed to decide, and probably the patients should decide? Even a 1% benefit is significant.
Well, that's also a very, very relevant question. Well, it's absolutely certain that we need to talk to patients. And we rarely involve them in the design of these de-escalation trials. So what we did 3 years ago in BIG was to convene a group of patients and patient advocates and to discuss de-escalation with them. And we learned quite a lot. So for example, we learned that in general, they will not be so much in favor of a de-escalation trial if the treatment you de-escalate is not significantly toxic. So for example, when we discussed, you will be amazed at that, we discussed the duration of trastuzumab. 3 months, 6 months, 1 year, de-escalation of the duration of this drug. The answer was that it's not something that they find very exciting because they know that once the chemotherapy is over, the drug is extremely well tolerated. On the contrary, when we discussed the escalation of toxic chemo, and particularly anthracyclines with the risk of leukemia, cardiotoxicity, they got more interested. They thought that this was more relevant. And then when we came to your point, what is the percentage that they would be ready to give up in a de-escalation trial? We saw that this is dependent on age of the patient. So the young patients are not so willing to give up, even 2%. They have young kids, they want to be there to raise them. So the women above 60 with grown-up kids were more open to start discussing losing perhaps a chance, but at the bottom line was around 3%. So greater than 3% was not flying, you see? So we concluded that 3% is reasonable, but it could still be unreasonable for some women. So it needs to be discussed at an individual level. But 3% is acceptable, but the message was also de-escalate what is really worth de-escalating. Interesting, right?
With respect to the hormone receptor positive tumors, I would like to know, do you think there would be some subset of patients who are hormone receptor positive, but still can get away without hormonal treatment? Of course, the side effects are much less as compared to chemo, but still there are some side effects.
Yeah. What was the question for these patients?
Do you think there would be some subset of hormone receptor positive patients who may not need hormone therapy at all?
From
the de-escalation perspective.
Yeah. The answer to that is probably yes, but how are you going to find these women? You see, knowing also that you have only one chance of getting rid of this bad disease. And with hormonal treatment, you have also the prevention effect for the other breast. You know that it's not only reducing metastatic disease, but it's also preventing. It is a question that our Canadian colleagues wanted to address in big. So they started discussing that at the big meeting. And one of the ideas was we start by giving 2 years. So we don't completely avoid endocrine treatment, but we decide that 2 years and not 5 years could be sufficient for many women. But then there was all this anxiety around, are we going to put these women at risk? What about a ctDNA monitoring? But how do we know that a single ctDNA measurement after 2 years of endocrine treatment is something reassuring enough? So you are probably right, but I find these trials very difficult. They are now discussing also a trial for TNBC, no chemotherapy in triple-negative breast cancer with a lot of TILs, like 80% of TILs in the tumor. And I don't know if I am going to put a young patient in such a study. I think, yes, there is a rationale, it looks attractive, but what if it's the wrong thing to do, you know? So I rather would go for a cautious approach. So you remove elements of the treatment one by one, and perhaps collaboration there would be good, because if we do that in sequence in 15 years, we will be nowhere. So we should do perhaps a multi-arm effort trial with one group avoiding the anthracycline, another one, something like that, you know. But really to go from a treatment to zero makes me very nervous personally.
A few more questions from my colleagues. One is regarding, this is from Dr. Roshni Das Gupta. Is there a role for CDK4/6 inhibitors in HER2 positive breast cancer, especially with reference to the Monarch HER trial? And also because we know the fact that one of the mechanisms of HER2 resistance is the cyclin D1 amplification.
So,
sorry, go ahead.
So the question is what I think about the Monarch E study.
Monarch HER.
Yeah, the adjuvant trial.
Yes.
Yeah, I think I explained that in the beginning. You know that I am still, I wait for a longer follow-up. Maybe I am a little bit biased because there was a study done in Germany. I don't know if you remember Penelope. It was a trial where young women who had residual disease after neoadjuvant chemo, so very high-risk luminal B cancers, were randomized after surgery to get 1 year of palbociclib or nothing, except endocrine treatment, of course. And there was a benefit seen at 2 years that disappeared at 4 years. Now, it's palbociclib, and we know that the huge PALAS study is negative. But for me, the message was, we don't know what these drugs will do in the long term, so we need a decent follow-up before we can really start prescribing this treatment and all the expenses related to it to all the women that are considered high risk. So I wait for San Antonio because I think in San Antonio there will be an update of the trial. And if it's confirmed, then I think indeed we have probably a new interesting addition to our adjuvant treatments. But again, we will probably overtreat women. The way the trial has been designed is clearly going to push towards prescribing a CDK4/6 even to patients who were cured with endocrine treatment alone.
Yeah, Professor Purvish, no, 2 more questions. If no time, we can go to the next center.
Yeah, thank you so much, Linu. We'll move on to Hyderabad. Dr. Vamsi Krishna, over to you.
Good evening, everyone. And I think everyone in Hyderabad would like to join in congratulating Dr. Martine. That was a fantastic lecture. It was really nice to hear a whole emphasis on how a thought process has gone into the trial rather than just the trial results. That's something amazing. I think all of us in India can take heart from the big initiative, and hopefully in some time we could have something like an IG initiative, an Indian group initiative, and that would be really nice to see. We are running short of time. I'll just take a couple of questions which have come, a sort of similar questions that have already been asked previously. So what is your take on the role of TILs in both TNBC and HER2 vis-a-vis sensitivity to chemotherapy and upfront immunotherapy? That's the first question.
Okay. So TILs are clearly fascinating oncologists and pathologists. And, in particular, Dr. Roberto Salgado, the pathologist who has done most of the work on TILs, worked in my institute for several years. I know him very well. So he's a real TILs fan, let's say. But from what I've seen so far, what we can see is that TILs are strongly prognostic. That there is very little doubt, and that's the case both in HER2 positive and in triple negative. But where things are not, at least for me, very clear is whether they are predictive. And for HER2 positive breast cancer, you should know that Roberto Salgado is counting the TILs in a lot of trials, and is bringing this set of data to the EBCTCG in Oxford, and they are going to look across thousands of patients progress. I cannot give you any results, but that's the way we are going to get an answer. Now, in triple negative breast cancer, it's the same. I think their prognostic value is well demonstrated. The predictive value will need a lot more work.
Thank you. I think that was really a nice way of putting it. So again, the second question is regarding something that in India we are very fond of, something called low-dose immunotherapy. Again, we are giving nivolumab at say 0.1 mg per kg or certain lower doses. There is a trial already which has shown that it works for head and neck cancer. Any thoughts on low-dose immunotherapy for breast cancer?
I have no answer, but I think that this is clearly an important question. And I would encourage you to design a trial that can show that we don't need the recommended dose or that we don't need the recommended duration. At the ESMO meeting, there was one of the best presentations, most striking one, besides the one with lidocaine from Dr. Gupta, was this trial from the Netherlands where they gave 2 doses of nivolumab to patients with big colorectal tumors, MSCI, and they had complete responses in almost all the patients, So I think in India, indeed, working on trials like that would be phenomenal. And I don't know if there are mechanisms for you to do that, because these academic-led studies still are expensive, right? You need some support. You cannot do that like that. And I don't know if there are mechanisms by which you can do these academic trials with at least a little bit of support.
I think that's something which we are all looking into in India. And if not today, definitely in the near future, we are going to go there. We are going to be there.
Talk to your government. You have to talk to your government. If they don't encourage this research, they will have to pay huge amounts of money to pharma.
Yeah, definitely we should put that to them. Last question is again regarding something that you did touch upon. Is there any benefit of doing NGS testing in recurrent triple negative cancers, 3-4 lines down the line? And if you get an unusual mutation, say an ALK positive, would you really use that target? That's what we are doing in other cancers. Is it something that in breast also should be followed?
Well, that's a very, very difficult question. Right now, I think you have also to map which drugs you have access to. Because the worst thing that can happen is you spend money to do NGS on a tumor, you find an actionable aberration, or at least actionable perhaps in other cancers with a drug, but you don't have access to the drug. So I think it's the first question you have to ask yourself is, are there enough targeted drugs accessible for the test to be of any help, you see? We recently got refusal of reimbursement of alpelisib for breast cancer in Belgium. I don't want to know if my patient has a PIK3CA mutation anymore, you see? It's too frustrating because I cannot give the drug. So it depends really if you can match the drug to the aberration. And then if it's an aberration that is known to be important in another cancer, we don't know what it is doing in, for example, breast cancer, that's where we need some collaboration of oncologists in a country. So in Belgium, we are trying to collaborate on those questions to have a mechanism by which if an oncologist finds an aberration, tries a drug, we can at least capture the information and learn from the experience. So, but that requires a little bit collaboration and sharing of the data.
Thank you, ma'am. I think that was a very reasonable answer, and it would be great if everyone in India followed such cost-effective methods and not just order tests. Thank you so much, and over to Dr. Purvish.
Thank you very much, Dr. Martine. We really appreciate you being here with us for so long. But I must share with you that more than 550 oncologists were listening to your expert and detailed comments that you have made. Without wasting much time further, I would hand over to Mr. Manoj to give the vote of thanks.
Ma'am, you were wonderful, superb. These are some of the small words from my side, and I look forward to meeting you in Belgium whenever I am. I must say that you had a comment for pharmaceutical company as well. It is not just government initiative that they should support research, even if it is not related to a drug. It is also for us that we should. So whatever is possible on our behalf, and I'm sure there are many like-minded pharmaceutical company across the globe will be willing to collaborate and work in whatever capacity we have. So rest be assured that we will pitch in our bit. Thank you indeed, Dr. Sudeep Gupta, Dr. T. Raja, Dr. Minu Walia, Dr. Linu Jacob, Dr. Vamsi Krishna for those wonderful questions. And also an apology to all those who had many more questions in the pipeline. But as we committed, we would start on time and we will close on time. And a very, very big thank you to Dr. Purvish Parikh and Kavinya Creations for putting this. It is very difficult to get your dates, ma'am, but thank you. It was worth the wait.
Thank you.
Final comments from Dr. Sudeep Gupta, please.
Yes, sir.
No, I have no further comments. It was a pleasure and privilege to listen to Dr. Pickard as always, and we look forward to future interactions with you as well. Thank you so much.
Thank you.
Thank you very much, and good night to everyone.